Thank you so much for your patience.
Hello, can you hear me now?
Good evening. So,
Good evening.
was stuck. Now it's fine. It's fine.
So you can hear me now? The voice is clear and the video is clear?
Yes, it is now clear, sir.
Okay.
So I'll just start with a quick intro, sir. Then we can go ahead with the session.
Okay.
Recording in progress.
Good evening, everyone. Welcome to Assembly. For today's webinar by Midvarsity. I'm Dr. Lavanya and I'll be your host for this session. We have a very exciting session planned for you today. We'll be listening to Dr. Islam Mustafa Mohammed speaking on transposition of greater arteries through some prenatal diagnosis. But first, let me give you a very quick introduction to Midvarsity.ae and Assembly.1. We are Asia's largest and fastest growing healthcare edtech company. We engage with a community of 500,000 healthcare professionals across 192 countries. In United Arab Emirates, Midvarsity.ae offers online CME courses accredited by Dubai Health Authority and CPD Standards UK. Assimilate.1 helps healthcare professionals gain broader insights into the current advancements in the medical field all under one roof. Assimilate hosts over 10,000 hours of medical video library for healthcare professionals. Case discussions and webinars covers over 20 plus medical specialties. Now I would like to introduce you to our guest speaker, Dr. Islam Mustafa Mohammed. Dr. Islam is currently working as fetal medicine specialist in NMC Royal Hospital in UAE. He has been practicing fetal medicine in Cairo University Fetal Medicine Unit for many years before and was acting as fetal medicine consultant in Egypt before joining the NMC group in UAE. He is the member of International Society of Ultrasound in Obstetrics and Gynecology and also a member of Egyptian Medical Society of Echocardiography. He was invited as a guest speaker for various conferences nationally and internationally. He completed Diploma of Fetal Medicine Foundation UK, certification in fetal echocardiography, obstetric and gynecology ultrasound from American Registry of Diagnostic Medical Sonography, fellowship of Ian Donald School of Medicine, and advanced professional diploma of maternofetal ultrasound from Cairo University. Now I request all the attendees to pay a very close attention. There will be a FAQ session at the end. However, I implore you to share your discussions, ideas and thoughts in the chat box or Q&A session. This will keep the discussion interactive and engaging. Now I request Dr. Islam to start with the session. Over to you, sir.
Okay, thank you so much for this nice introduction. I just want to make sure that my voice and my voice is clear.
Yes, sir, it is clear.
Okay, so I think I'm going to start my presentation right now. So the presentation is on the screen right now.
Yes, sir. Sir, can you place it on a full screen?
Full screen, yes. Okay, just please. Okay, now it's in full screen.
Yes, sir.
Okay, so I thank you for this very nice introduction, and I thank everyone who will spend some time with me in this important topic on prenatal diagnosis, transposition of great artery. So, as you see, my talk will be about transposition of great arteries, clues on prenatal diagnosis. First, I'd like to shortly introduce myself. I was working as a fetal medicine consultant in Egypt. After getting my OB and gynae degree, I have joined Cairo University Fetal Medicine Unit, the biggest tertiary center in my country. And since then, I have been working exclusively in the field of fetal medicine. I was honored to obtain the diploma of the Fetal Medicine Foundation. I am also licensed from the American Registry of Diagnostic Medical Sonography in many things, including the OB-GYN ultrasound and fetal echocardiography. I also have the fellowship of Ian Donald School of Medicine, and I'm also a member of the ESOG-VSOG task force. It's a great source for learning. I invite every one of you to try to navigate this very important source so that you will see a lot of chapters on prenatal diagnosis. And my talk today will be about transposition of great arteries. My current designation is that I'm working as a fetal medicine specialist for NMC Royal Hospital in United Arab Emirates. So before starting my talk, I just want to mention a very, very important concept on prenatal diagnosis. It is the concept of pattern recognition. What does we mean by pattern recognition? This words was written on the Fetal Medicine Foundation site by Prof. Lindsay Allen, and I was extremely inspired by these words. It said that ultrasound diagnosis is about pattern recognition, your ability to distinguish what is normal from what's an abnormal. If you can recognize an abnormal appearance and describe accurately why it's different from normal, you can reach the correct diagnosis and from that an idea of prognosis. What does this mean? This means that in ultrasound diagnosis, in order to be perfect in ultrasound diagnosis, you have only to customize your eye to what's normal. So that when you see an abnormal image, you will, number one, realize that this abnormal image is different from what you used to see. And the second stage is try to describe why this abnormal image is different from the normal image. This is very important because once you do this pattern recognition, you will know the diagnosis. And it's easy to know the prognosis and the management. It's just information. But the most important part is the pattern recognition. And this is what I'm going to focus on my presentation. For many years in my ultrasound teaching, I've been using this very simple method to simplify everything. You have two images, one image to the left and one image to the right. Imagine that the image to the left is a normal image, then the image to the right is the abnormal image. You have to get your eye used to this normal image so that when you see the right image, you start to understand that it's different from what you used to see. You will then have to describe why this image is different from the normal. And then when you can describe this, you can reach the diagnosis because you have already made the pattern recognition. To give an example from prenatal diagnosis, these are two cases. Imagine the case to the left side. It's very easy for you, even if you're not a doctor, to understand that there is something bulging out of the fetal abdomen. I don't want you to say that this is fetal omphalocele. I think it's already easy to know that this is fetal omphalocele. The pattern recognition in this case is very easy. But I don't think this is the case for the image on the right side. Okay, because for the image on the right side, you have to have some experience to understand that the chin is receding backwards and the ear is low-set ears and posteriorly rotated. This is a proven case of trisomy 18. So the process of pattern recognition sometimes can be so easy, but sometimes is not so easy. This is also applied to what we see in the fetal heart. In the fetal heart, sometimes the pattern recognition is very easy. Like this case, I don't think it's very, I think it's very easy for you to understand that the heart is bulging out of the fetal abdomen. This is a straightforward diagnosis of ectopia cordis, but this is not the case to the image of the right side when you have a case of crisscross heart. I don't want you in this presentation to know what's crisscross heart. What I just want to tell you is that this process of pattern recognition can sometimes be easy, like the images on the left side, but sometimes it's very, very difficult, like the images on the right side. So let's start to see how we examine the fetal heart. We can examine the fetal heart by two methods, either something called the sweep technique or something called the rotational technique. In the sweep technique, you put your ultrasound transducer on the fetal abdomen, and then you start to move your ultrasound transducer upward toward the upper mediastinum. This is what we call the sweep technique. In the rotational technique, we respect an anatomical fact. What is this anatomical fact? The anatomical fact is that the aorta go to the right shoulder before returning back to the left side. So the aorta assume this position you see on the screen. So what we do in our transducer is that we curve our transducer toward the right shoulder to get the aorta in its entire length. So this is the sweep technique to the left side, and this is the rotational technique to the right side. What's easier? I think that the sweep technique is easier than the rotational technique, and it's the most commonly used, but the rotational technique is the best technique. So it's very simple for you to start with understanding the sweep technique because it's very easy and you can apply it immediately in your everyday practice. So this is a sweep technique. You put your ultrasound transducer and you sweep until you reach to the upper mediastinum. This is the sweep technique. Okay, let's have some ideas about examination of the fetal heart. Of course, this is a very short webinar in which I don't have enough time to elaborate on examination of the normal heart. But I just want to give you some small hints about examination of the fetal heart. If someone in the attendees have never seen something like this, we start by the abdominal circumference, by the abdomen, getting the plane of the abdomen. It's not necessarily to get the plane, the ideal plane for the abdominal circumference. You just need to go to the fetal abdomen to make sure that the fetal stomach in blue color and the aorta in the yellow color is located to the left side of the baby, and that the liver and the inferior vena cava, I've labeled it in red color, is present toward the right side of the fetus. How can you know the left and the right side? From the position of the fetus. And if you're practicing ultrasound, you should do it easily to know where is the left and where is the right side from the position of the baby. So you want to make sure that the stomach and the aorta is to the left, and then the aorta and the inferior vena cava to the right side. Then you go slightly upwards to see the four chambers views. These are the four chambers views. In the four chamber views, you see the four chambers of the heart. How can we label that? Is the arrow clear in the screen? The arrow is clear on the screen?
Yes, sir, it is clear.
Okay, so the arrow is at the beginning. So the chamber I'm just trying to put my arrow on is the left atrium. How can we know that? Because it is the closest to the spine. Okay, so and the chamber, most anterior chamber close to the fetal sternum is the right ventricle. You will see two valves opening and closing, and then you will understand that this is the left atrium, this is the left ventricle, right atrium, and the right ventricle. Of course, to do this process perfectly, I have to spend with you some hours to explain in details how we examine the normal heart, but I'm just giving a very quick hint. So after we're seeing the four chamber views, the left atrium, the left ventricle, the right atrium, the right ventricle, you will take your ultrasound transducer and then sweep to the right shoulder. As I told you, this is the rotational technique. What will you see? You will see the aorta along its entire length. Okay, the aorta is coming from the left ventricle. In the previous slide, I told you that this is the left ventricle. You will see the aorta coming out of the left ventricle in all its entire length. So this is the aorta. Then you take your ultrasound transducer and sweep upwards toward the upper mediastinum. And when you go to the upper mediastinum, you will see the three vessel view, the pulmonary, the aorta, and superior vena cava. Of course, the pulmonary in blue, the aorta in yellow color, and superior vena cava in red color. These are the three vessel views. Of course, it needs more explanation, but this is a very quick hint on examination of the fetal heart. This is a video that I've made back in 2018 to make an integrated idea of this technique: left atrium, left ventricle. Can you see the aorta? This is the aorta, and I'll take my ultrasound transducer and go upwards. Then I see the pulmonary, the aorta, and the superior vena cava. Okay, so this is a very quick hint about examination of the fetal heart. And I hope that I can meet you in a coming meeting to explain more and more. I think I need some 4 or 5 hours to make this very clear and to mention all the points that we have to take care of during examination of the fetal heart. So let me start explaining the transposition of great artery. And my concept in this presentation is to focus on the pattern recognition. I don't want you to know what is a switch operation, what is the Rashkand procedure, the association. Although the association here is very difficult because it's one of the congenital malformation that is not commonly associated with chromosomal anomalies or extra cardiac anomalies. But this is not what I'm aiming at in this talk. What I'm aiming at is to focus on the pattern recognition. This is a normal heart where you see the superior vena cava, the inferior vena cava draining into the right atrium. Then the right atrium is opening into the right ventricle. Then the pulmonary artery is coming out of the right ventricle. The pulmonary artery, of course, in blue color. Then you have the left atrium, the left ventricle, and the aorta coming from the left ventricle. What will happen in TGE is that the pulmonary and the aorta gonna switch. Okay? So the pulmonary will come in place of aorta, and the aorta will come in place of the pulmonary artery. So instead of having this very nice picture, what you will have is this picture. The pulmonary has now come out of the left ventricle, and the aorta is coming from the right ventricle, what we call ventriculo-arterial discordance. What does we mean by ventriculo-arterial discordance? Is that the connection between the ventricle and the great artery is now discordant. It's not going normally. The left ventricle should be connected, the right ventricle, sorry, should be connected to the pulmonary artery. No, in TGA is connected to the aorta. And the left ventricle should be connected to the aorta, but in TGA, no, it's not connected to the aorta, it's connected to the pulmonary artery. So what you will have here is that the right atrium connects to the right ventricle, and the aorta is coming out of the right ventricle, and the left atrium is connected to the left ventricle, and the pulmonary artery coming out of the left ventricle. Is this serious? This is very serious, very, 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 very serious. What I'm explaining now is a postnatal circulation, not a prenatal circulation, postnatal circulation. What will happen is that the blood, focus your eye on the blue dots. The blood is coming from the pulmonary vein, going to the left atrium, then to the left ventricle, then going to the pulmonary artery, and from the pulmonary artery to the lung, and from the lung back to the pulmonary vein. So all the oxygenated blood will stay on the left side. All the oxygenated blood will come out of the lung to go back to the lung. And what will happen for the deoxygenated blood from the superior and the inferior vena cava to the right atrium, right ventricle, but to the aorta? So the deoxygenated blood will return back from the aorta to the heart again. So you have two parallel circulation, a circulation to the left side, oxygenated circulation, and a circulation to the right side, deoxygenated circulation. And in order for this baby to do well, you should have a hole in the heart. You should have some form of shunting between the two sides, and this hopefully is associated in cases of TGA. So I will return back to the process of pattern recognition, the slide that I have mentioned at the first of my presentation. The normal image and the abnormal image. This is the normal image to the left side, and this is the abnormal image to the right side. Can you see the difference between the great vessels in the left side and in the right side? The great vessel in the normal heart is crossing over at the site of the origin. It's important to mention that this happened at the site of origin, not distally. I will explain this in more details shortly. So in normal cases, the great vessels are crossing on each other at the site of the origin. But in abnormal cases, this doesn't happen. In TGA cases, the great vessels are parallel to each other. If you have compared the two great vessels to each other, you will see that they are crossing over at the origin in normal cases, but they are parallel in cases of TGA. To explain this in more details, I'm getting a stick volume from the fetal heart, which I have made in the mid-trimesteric screening. This is a stick volume from a normal case. You can now see, you will see now how the two vessels are crossing at the site of the origin, but they are parallel distally. You will see now. We're looking now from the front of the heart, okay? And this is the pulmonary artery, and this is the aorta. They are crossing each other at the origin. Now we will start to see the heart from the lateral aspect. See what will happen? They are both coming to be parallel with each other distally. You will see the parallel connection now. I will label it now. Okay, you will see this parallel connection. So when you see this parallel correction in parallel orientation distally in normal heart, what we call the V sign, don't misdiagnose this case as TGA, because you will have everyday normal cases misdiagnosed as TGA. This is just a V sign. This is just parallel orientation of the great vessels distally where the aortic arch connect to the ductus arteriosus. Okay, so you have to make sure in order to diagnose TGA that this crossover doesn't happen at the that this crossover normally happen at the origin. Okay, but if you see parallel orientation at the origin, this is TGA. Can you see the difference in orientation at the origin and the insertion in this video? This is a typical view. I don't want you to get this view in every normal case. I'm just getting this view for you to make you understand the difference between the crossover orientation and the parallel orientation of the vehicles. So at the first side, they are crossing with each other, but distally, they are connecting with each other. They are parallel. This is not clear. This will be much more clear. This is the crossover at the origin, and when you go distally, this is the V sign. So this is normal. When you see this, this is normal. When we say parallel orientation, we mean that this parallel orientation occur at the origin, not distally, because distal parallel orientation is normal. So let's see this crossover in 2D images. This is a normal heart. This is a normal heart. I will use my arrow. This is the left atrium, and this is the left ventricle, and you can see the aorta coming out of the left ventricle. When you take your ultrasound transducer and swipe toward the upper mediastinum, you will see the three vessel view: the pulmonary, the aorta, and the superior vena cava. If you notice the orientation of the pulmonary and the aorta, and you convert this in your mind, this is a lower plane, this is an upper plane. If you see the orientation, they are making something like crossover, and this is how you can see this crossover at origin. This is normal. This is what you will find in normal cases. These are old stick volumes I have made back in 2018, and I don't think they are important. Let's see the case of transposition of great artery, and let's explain what we have demonstrated at the start of my presentation on this video. I just want you to see this video silently for some 1 minute or so. Okay, let me try to make it easier for you. This is the left atrium, this is the left ventricle, this is the right atrium, and this is the right ventricle. See what will happen and what will come out of the left ventricle. Can you see now the pulmonary artery is coming out of the left ventricle, and the aorta is coming out of the right ventricle. How we can know the pulmonary artery? Because the pulmonary artery stays for a short distance, then it bifurcates. This is how we know the pulmonary artery. You can see this illustration of the video. So the pulmonary artery now is red and the aorta in yellow color, and you can see how the pulmonary is coming out of the left ventricle and how the aorta is coming out of the right ventricle. This is the parallel orientation of the great vessels. Okay. So again, this is how can you apply the crossover knowledge to diagnose the transposition of great arteries. The pulmonary is coming out of the left ventricle, and the aorta is coming out of the right ventricle. And this is the parallel orientation. Let's try to go back to our pattern recognition slide and you want to apply what we have learned in this pattern recognition on cases, normal cases, and transposition of great artery cases. You can now see the normal and the abnormal. The normal will be to the left, and the abnormal will be to the right. Can you see the difference? This is a normal case. This is an abnormal case. This is a transposition of great artery case. Here you can see the left atrium, the left ventricle, and from the left ventricle, the aorta is coming. This is the aorta. How we can know the aorta is coming all through? No proximal branching. But can you see here in the abnormal case, this is the left ventricle. What's coming out of the left ventricle? A vessel, short, it bifurcates soon into the right and the left branch. This is the pulmonary artery. This is what you should see in normal cases, the aorta, and this is what you see in transposition of great artery, the pulmonary artery, coming out of the left ventricle. If you go to the upper mediastinum, in normal cases, you will see the three vessel view, the pulmonary, the aorta, and the superior vena cava. This is a short mnemonic, BAS, pulmonary, aorta, superior vena cava. But in transposition of great artery cases, what happened? What happened is that instead of seeing three vessels, you will see only two vessels. The vessel coming anteriorly from the anterior of the heart is not coming straight like the pulmonary artery. No, it's not coming straight. It's assuming the normal curve of the aorta. So what's coming anteriorly from the heart is the aorta, not the pulmonary artery, as should happen in normal cases. So if you compare the normal pattern from the abnormal pattern, I think the process of pattern recognition will be extremely easy, and you can diagnose transposition of great artery with confidence. Of course, if you don't have experience in such complicated topic, you can suspect and then send your case to a more experienced center for a definite diagnosis. But this is how can you suspect it in your everyday practice, and I think it's not complicated. It just needs something. This is a stick volume, what we call the 4D ultrasound. And I'm using this technique a lot in this presentation because it's beautiful in demonstrating the abnormal anatomy. Here you can see the aorta. This is the aorta coming anteriorly, okay? If you can notice the aorta is giving branch to the neck. So the vessel that gives branches to the neck is most probably the aorta. So the aorta is coming anteriorly, while the pulmonary is very short and is coming posteriorly. And both vessels are parallel in orientation. They are not making the crossover. This is where the aortic valve is situated, and this is where the pulmonary valve is situated. And they are making parallel orientation. The aorta is parallel to the pulmonary artery. The aorta is anterior and to the right to the pulmonary artery, and this is what we call the transposition of great arteries. You can see the aorta, and you can see the parallel orientation of the great vessel. You can see the branching pattern of the aorta where it gives the branches to the neck, and the pulmonary artery is short because it will bifurcate into the right and the left pulmonary artery soon after it's emerging from the fetal heart. Of course, in this presentation, I'm focusing on the D transposition of great artery, not the L transposition of great artery, because the DTGA represents in many cases a neonatal emergency. In cases of LTGA, many of these cases can do well, except if it's associated with other malformations. So the DTGA, this is what we need to focus on. So my take-home message is pattern recognition. I will go back. This may be the fourth time I mentioned this slide in this presentation because it's very important. The normal image and the abnormal image. So this is to the left side, this is a normal heart. To the right side, this is a transposition of the great artery. Sorry, I have switched now. The normal heart is to the right side, and the abnormal heart is to the left side. Switch it, okay? So this is the normal case, and this is the abnormal case. And you can see now, I just want to summarize this lecture in this video. This is the left atrium, this is the left ventricle, this is the right atrium on the right ventricle. This is TGA. This is the left atrium, this is the left ventricle, the right atrium on the right ventricle. We will go upward now, and what you can see What you can see in normal heart, the aorta is coming out of the left ventricle, but in abnormal heart, the pulmonary artery, very short, bifurcating zone coming out of the left ventricle. When you go to the upper mediastinum, so in normal heart, you will see the three vessel view, the pulmonary aorta superior vena cava, but in TGA, instead of three vessel, two vessel, the aorta is assuming the normal curvature of the aorta and is coming anteriorly from the heart instead of the pulmonary artery. And now I reach to the end of my presentation. Hello?
Thank you, sir, for taking your time out for us and giving such a wonderful session today. It was really an informative session, sir. So before we further go to the questions, can you tell us any 3 take-home messages for today's session?
3 take-home messages? Okay.
Yes, sir.
Okay, the first message is that examination of the fetal heart is extremely important, extremely important. In fact, we do that routinely in the mid-trimesteric scan. When the patient comes to do her second trimester, usually between 18 and 23 or 24 weeks, we do what we call fetal cardiac screen, getting some basic views like the one I have showed in my presentation. This should be done to every pregnant woman, whether this pregnant woman is high risk or low risk patient. Okay? But when the case is high risk, you can send the case to something called the fetal echocardiography, and this is my second message. The cases of high risk can go immediately to do the fetal echocardiography. And maybe the most frequent high risk patients are those when they are going to do the basic cardiac screen, but something turned out to be abnormal. This is when the case is transferred from a low-risk patient to a high-risk patient. Then she should go to the fetal echocardiography. So my message, fetal cardiac screening for all pregnant women, because the vast majority of congenital cardiac malformation come from low-risk patient. The second message is that high-risk patient can go to a service called the fetal echocardiography, where a more advanced fetal cardiac examination is done. And my third message is to focus on the concept of pattern recognition. You don't need to memorize everything in each textbook because the textbook is in front of you. You can go back to the information anytime, but you have to make your eye used to the pattern recognition because this is how you can catch the abnormal cases.
Thank you so much, sir. So I request all the attendees, if you have any doubts or any questions, please write it down in the chat box or Q&A session. We'll be taking up the questions. So sir, just we'll wait for like 5 minutes. We'll get the questions. We'll take the questions.